A local, married Matt, and we live with our 3 boys on a farm outside of Bullaroo. I'm the founder of Hats Off for Health Chats, which is a side project of my initial project, Good Gracious Gut. I'm really passionate about rural health. I'm a rural person myself, and I really feel strongly that we should have access to similar services or equitable services that metropolitan counterparts do. Sometimes, due to sheer distance, and we can't do anything about that, we might not have the access to the tertiary hospitals as easily as what city people do. But information, I think, should be equal, and that's where my idea for Good Gracious Gut came about. I thought that more people needed to know about gut problems, and I know I'm a bit biased, but things like hemorrhoids and bleeding and diarrhoea and things like that, I thought we don't talk about enough if they are present, because it's not the usual chit-chat that's easy to talk about. And so I thought that a blog site where I could upload a few articles might be able to help that situation. Then I did realise it wasn't only gut problems that people should know about. There are other important areas of the body which we should know about, important topics. So I thought, well, what if we could create a space where we have information nights for men and women? And I'm not getting political into the men and women issues here, so please don't ask me too much about that. But I thought that it would be nice to split up men's and women's topics, have a really down-to-earth chat, if you just wanted to listen or if you wanted to ask questions, but also just to catch up with friends and enjoy good food and a few drinks. So that's where Hats Off for Health Chats, the idea came from. I can't claim I came up with the name. Damien Somerville's wife helped me out there, Ruth. I had to ask her a few questions and she quickly came up with the name. But I've been really excited to put it together. The idea's been there for a couple of years, but really only got up off the ground and running over the last sort of 6 months. Before we start, we've got some great speakers tonight. At least 3 out of 4 are really good speakers. I don't know about myself, but I've got some wonderful speakers to introduce later on as we go. But I'd just like to thank a few different groups and people that have helped me get this project up and running. So firstly, AgriFutures. I was lucky enough to receive a Rural Women's Acceleration Grant to help support the idea and get it up off the ground and running. And they've been tremendous in their assistance and mentorship. Dale and the Jacker Brothers Brewery have been fantastic to work with. You can all agree it's a fantastic location, and Dale has been excellent to work with, really supportive of the idea, and has offered sponsorship as well for the event. Meredy, who's offered sponsorship with the videoing. So if your loved ones wanted to watch the talks tonight, or if you had friends that missed out, or if you're keen to listen to them again, they'll be uploaded in the next few weeks, hopefully, that you can view. The other people I'd like to thank are Giza, our Gastroenterology Society of Australia, and also Kerry, who's put on a beautiful spread of food for us tonight to share. But hopefully you've all managed to come early to get some food there. I think that's all my thank yous. I apologise if I've missed anyone. Because I'm the organiser, I got to choose the order of the talk. So I thought I'd get mine off the ground running so I can enjoy the last 3 speakers. So I've decided to talk about bowel cancer and gut health. I'm very passionate about bowel cancer and trying to spread information about it, really to lower the incident rates of bowel cancer, because Australia has one of the leading rates of bowel cancer, which is quite astonishing in this day and age, given that we're such a developed country and have access to the facilities and technology that we have. We don't like talking about our bowels, which is understandable. But really we should be able to feel comfortable in talking about any abnormality that we have, if not with our family or our friends, at least having the comfort of knowing that you can talk about it with your GP if you think that something is wrong. I'm not sure why when we have babies, suddenly everything is about poo and bodily functions, and we tend to be, sometimes quite obsessed with whether they've had poos or not had poos, and how much, and whether it's exploded or not. And then we get to the toddler phase, and then it's potty training, and we're talking about, oh, good, well done, you have a poo, and that's excellent. And then you get to my age group where they're talking about poos all the time, and I go to work and talk about it all the time, and then I come home and I've got 3 boys that are talking about it. But somehow along the track, we're happy to talk about, children's bowel functions and gut problems, but we don't like to talk about our own if it's wrong, if it's abnormal, and sometimes almost we're scared to talk about it, hoping that it is normal and that it'll just go away. So I wanted to talk more about that tonight and hopefully answer some questions that people may have had or have. So what is bowel cancer? Well, bowel cancer is a cancer that affects the bowel, but where is the bowel and what type of bowel does it affect? So the first diagram on the right shows our gastrointestinal tract, anywhere from the mouth through the esophagus, stomach, the small bowel leading onto the large bowel on the right, where your appendix is, if you haven't had that taken out, going up the right side, under the ribs and down the left and out through the rectum and the anus. So your large bowel looks like that. And that's where what bowel cancer affects. It affects the colon or the rectum, so you often hear it referred to as colorectal cancer or rectal cancer. Cancer is an abnormal growth in the lining of the intestine, of the colon or the rectum. Now, in our intestines, we shed our cells of the intestines, all of them, about every 10 days. Obviously not all at once, in a sort of sequential fashion, and that comes out in our faeces along with bacteria and other waste products. And for every one cell that we lose, another one is made. So there's a nice balance and equilibrium, and bodies like balance. But if we have some damage to our cell lining and our cells, from different exposures, different chemicals, whether it be smoking or alcohol or age-related changes that damages that cell in that bowel, it may lose or gain the ability not to die, and it'll stay in the bowel. Now, if that cell then stays in the bowel, it can divide into 2, then into 4 and 8, and I've got to get my maths right, 16, 32. And then suddenly you've got a clump of abnormal cells that are in the lining of the bowel. Now, initially, this is simply called a benign polyp, a group of abnormal cells that probably won't do anything and is certainly not cancer at that stage. But we know that about 1 in 20 polyps in the bowel can progress to cancer over around about 5 years. Some are more aggressive, some are slower than others. So not all polyps can be harmful, but some can be, and that's where we really need to intervene to try and find these polyps and remove them before they can become cancerous. Polyps are fairly common, so 15 to 40% of people will have a bowel polyp sometime in their lifetime, more common in men and more common as we get older. Alarmingly, in Australia, over 15,000 cases of bowel cancer occur each and every year. And of that, over 5,000 people with bowel cancer will pass away each year in Australia. And as I mentioned before, we have one of the leading rates of bowel cancer in the world. We often think about it as an old person's disease, but you can see here, alarmingly, nearly 10% of people diagnosed with bowel cancer are what we call young onset or are diagnosed below the age of 50, and 5% of our deaths come from that group of people. Now, we don't know why this group is so prevalent, and it's actually increasing the rates below 50, and I'll talk a bit more about that later, but it is an extremely concerning fact. And if we put all the incident rates together, we've probably got a 1 in 15 chance of having a bowel cancer. Now, that may change depending on whether you've got a family history or other risk factors, but generally speaking, the broad population, it's about 1 in 15. So just going back to polyps, as I mentioned, they're initially quite benign and majority won't cause cancer. And often they start off very small, so a couple of millimetres in size. But with time, they might develop more and more mutations and damages to the cell's DNA. So then they grow a little bit more, and they grow a little bit more, and then they might take on other advantages to those cells that allow them to feed off of blood vessels and get more nutrients. And then eventually they're more and more capable of becoming a cancer and then possibly even then spreading. Now, turn away if you don't want to see a picture of what a polyp looks like. These are 2 pictures here that I've taken of polyps off over the years. Obviously these are very large polyps. These will no doubt have turned into bowel cancer, but you can see there on the right of your screen the nice healthy bowel with normal blood vessels, and you can see that that polyp is quite abnormal, an abnormal growth. This one here you can see is actually sitting on a stalk there, and this is the polyp that we need to take off. So polyps can look quite flat, some of them can look quite depressed, or some can sit up like a mushroom. So who gets bowel cancer? Bowel cancer can affect men and women, young and old. We think that men are at more risk than women, slightly, and probably due to the risk factors associated with bowel cancer. So we know that men consume more alcohol on a general basis, they consume more red meat, and are often more likely to smoke, which are three most common risk factors for bowel cancer. I mentioned about it affecting both the young and the old. The peak incidence is around 70 to 80, but it really starts to really increase after the age of 50, and that's why our National Bowel Cancer screening program targets 50-year-olds or above 50-year-olds. But family history has a significant role too. So 30% of bowel cancers diagnosed, someone will have a family member that is affected, and that might be one family member in terms of an uncle or someone a little bit more removed, or there can be a cluster of people in their family that have bowel cancer, their father, their two uncles, their cousin and what have you. And usually in that scenario, it's a hereditary condition. We know the specific gene that has increased their risk of causing cancer quite exponentially, and it can be tested most of the time. And this was, I think, one of the most important statistics, though, that if we do catch bowel cancer early, 99% of cases can be cured. The trouble is, less than 50% are picked up early, and that's where we need to work on and try and get that pickup rate much better than that. So what are some symptoms potentially that may be a sign of something sinister like bowel cancer? Well, I usually say any change in your bowels that are abnormal for you and that last at least 2 weeks is abnormal and could potentially be a sign. Now, this then comes back to knowing what your own body is and knowing what's normal for you. So someone's normal bowel habit might be waking up in the morning, having a cup of coffee and then going straight to the toilet. Someone else might be, they've had 20 years of going 3 times a day with a little urgency, but they go and it's maybe a little bit loose, but it's been normal for them. Other people might only go once a week, and if it's not causing any problems to them, then this is normal. But if suddenly the person that goes once a week is starting to go twice a day, or the person that's going 3 times a day suddenly has quite a hard stool and is not going at all, or very little, then that's abnormal. There's been a lot of gastro that's been going around the mid-north, so obviously that's something that only lasts for a short period of time usually. But if anything stays that is abnormal and different from the person's normal, then they should see their GP and be further investigated. Not always is it going to be something like bowel cancer, but they might need further investigation and treatment of a simple infection or change in diet or what have you. And if those changes then don't resolve the problem, then maybe they actually do need more further investigation to see whether it is something more sinister. Stool is always abnormal. Okay, so the majority of the time it can be something simple like hemorrhoids, but what's to say someone with hemorrhoids that bleeds doesn't also have a polyp or a bowel cancer that's bleeding at the same time? We don't know. It both looks like red blood in the bowl, so we really need to have a colonoscopy to look in the bowel to see what it is. And if it is hemorrhoids, then that's fine, and we might be able to offer treatment if it's needed or what have you, but it should always be investigated. A change in the shape of the stool can be important, so stringy stools that last for over 2 weeks possibly is a symptom. Having abdominal pain or swelling, and having a pain or a lump in the anus is also something that should be considered to have a chat to the GP about and further investigated. One of the tricky ones is fatigue. I've got young kids. I feel like I'm always fatigued sometimes. But sometimes that, coupled with if you go to your GP and trying to explain why people are fatigued and they find out that they're low in iron or you're anemic, that might be a sign that something's happening in the gut. And also unexplained weight loss is very important to further investigate. So we all have a baseline risk of bowel cancer, so 1 in 15, but what puts that risk up? in terms of being susceptible to bowel cancer? Well, we split those into modifiable and non-modifiable causes. So if we think back to the first slide where I said increasing age is important, well, we can't do anything about that, and I personally don't want to do anything about that. I want to be getting older. But there are things that are modifiable. So we know that smoking increases the risk of bowel cancer. So there's almost 70 carcinogenic agents in smoking that can attack the cell's DNA and possibly cause these changes. And the more that you smoke and the longer that you smoke increases your chances further. Alcohol increases the risk. So when alcohol is broken down to acetaldehyde, that can directly affect the DNA in the cells and potentially cause these changes as well. Now, we all should be aware of the guidelines, the safe drinking guidelines. So less than 2 standard drinks a day is optimal. But really, studies show that any drink of alcohol can increase your risk. Obviously, if you only have 1 drink a week or a month, that risk is very tiny, but it's always causing an increased risk. Obesity is another thing, so particularly increasing your abdominal girth, size, increases the risk. So people that are obese have insulin resistance, but in the terms of similar to diabetes, and that insulin resistance causes a lot of secretion of hormones that can act like growth factors and can alter the cells. And people who are overweight probably have a 1.3 times increased relative risk of having bowel cancer. And finally on the list is consumption of excess red meat or processed meats. So processed meats, the nitrites and the nitrates in them, the preservatives can potentially be harmful, and some chemicals in red meat, as we all eat our Metwurst tonight. Everything in moderation is my spiel. So non-modifiable age, family history we've talked about, and hereditary conditions. Other things that also affect the bowel for the long term can potentially increase your risk. So things like inflammatory bowel disease can do so also. Coming back to age and the young onset, there's so much research around the world looking into why more and more people under the age of 50 are getting bowel cancer. We think in this day and age it's possibly related to the risk factors that I've spoken about before and a really unhealthy Western lifestyle. So in this day and age we're consuming more alcohol, eating more processed meats, becoming more obese, less physical exercise, more smoking. But also there's probably some genetic component that we just haven't found out about yet. So that is where it comes back to, if you have any change of your bowels, regardless of what age you are, seek out help and further investigate, because it's probably going to be nothing, but if it isn't, you don't want to miss it. And that was just a little slide, I'm sorry that this side can't see it very well, but a little slide, or graph, showing that the increase rate really starts to increase up after the age of 50, and around the 17 to 80 mark is really high chance. So how is it diagnosed? Well, it's probably split into 2 groups. So we've got a group that if you do have a change in your bowel habits or bleeding or what have you, some symptoms, you're going to follow a different pathway of getting diagnosed to someone that enters the screening program. So the National Bowel Cancer Screening is free of charge. The program sends out a stool test to check for blood in the stool after the age of 50, and then every 2 years after that until the age of 74. Sorry, they're ageist. They cut you off after 74. But you can get these stool tests before the age of 50. They test for blood in the stool that you can't see. So if you've got bleeding that you can see in the bowel, you don't need a screening test, because you should be getting investigated regardless, generally speaking. But the stool test is there to pick up any bleeding that people don't have any symptoms of at all. And then not all people with bleeding will have a bowel cancer, but then you need to go on to have further investigations to work out whether it's something completely harmless or it is something that we need to worry about. And we do that through a colonoscopy. So the other group of people are the people that have symptoms, okay? So if you have bleeding in the stool or a change in your bowel habit, you'll go to the GP, you might have a stool test to check for infection, you might have a blood test to check whether you're anemic, you obviously have a good, hopefully thorough history and examination if you've got a good GP or a good doctor. Then they might go on to maybe organising some imaging, so a CT scan potentially. But then if it's still unexplained and if it's still ongoing, then a colonoscopy is your next best bet. So I brought some props with me. So, this is a colonoscope.
Any volunteers?
The nurses were very nervous with giving this to me on Thursday because, as you know, Sophie, they're very expensive, and so yeah. So this is what I use when I'm in theatre doing colonoscopies. Okay, this is hooked into a machine up here. Fibre optic cable. I have a light source, and I've got 2 dials on the left here that I can move up and down and left and right. And I've also got torque there. So I think, like many professions use this, plumbers use it and mechanics use it, and I'm sort of one of those in a roundabout kind of way. So I'm going all the way around the large bowel to try and find out what the cause of the bleeding or the diarrhoea or what have you. I've got a port or a channel here which goes through all the way through here. So there's a light source here but also a channel, or 2 channels actually. I can suck up things, but I can also put an instrument down to cut off any polyps or take biopsies. So I take polyps off. It's a little, what we call a snare. It's just a little wire that is quite sharp and that we can just cut them off there and then. And we're talking millimetres in the majority of time. But that's what it is. I don't use all of it. It doesn't usually go all the way in. Most of the time it's about 70 centimetres. But it's a pain-free procedure. You won't get a few jokes. It's a pain-free procedure. You're under an anaesthetic. It takes about 20 minutes. The worst part about it is your bowel prep at home, and you're in your comfort of your own home for the clean out. And I know that no one likes them. I really understand that. But if it's the sake of finding and picking up a bowel cancer early, to me, I think that it's a no-brainer. So that's how bowel cancers are diagnosed. After that, if a bowel cancer is diagnosed, then we usually need some more investigations after that, and that might include imaging, so a CT scan to see whether the bowel cancer has spread, and maybe some more blood tests looking for certain hormone changes and markers. All that information is then put together to give, one, the diagnosis, but also the stage of the bowel cancer. And the stage is very important in terms of early stage or latter stage, because it gives us a good prognostic estimate. If it's picked up early in an early stage, there's a good prognostic markers, and then you're likely to survive if you get the appropriate treatment. After a diagnosis is made, all of that information is then usually sent down to a tertiary centre, and a multidisciplinary meeting is then formed. So you've usually got gastroenterologists, the surgeon, this is usually after surgery has taken place, sometimes before or sometimes both. And the surgeon, the pathologist that's looking at underneath the microscope, the radiologist that's looking at the films, and then the cancer doctors, so the chemotherapy oncology doctors and the radiation oncology doctors. And they sit down and look at it case by case and work out what the best treatment is to give the best prognosis. And that usually involves surgery, possibly chemotherapy or radiotherapy, which are the traditional, what we call adjunctive therapies used. But there are some also newer ones with immunotherapy and targeted therapy. So that is if you get bowel cancer or if you have it, but I don't want people to have it. I want to prevent it, okay? So how do we reduce our risk of bowel cancer? One is reducing those modifiable risks, and the second one is utilising the National Bowel Cancer Screening Program. So as I said, this is a program free of charge that should be sent out to you in the post after the age of 50, a great 50th birthday present. In America, though, the research suggests that they've actually changed their guidelines and brought it back to the age of 45. And in Australia, we encourage people to be seeing their doctor and be using it now, and this has only been a recent change, that we should be using it from the age of 45. Unfortunately, there's not enough funding as yet to provide that free of charge. So just looking around the room, I think the majority of us probably over or getting close to the age of 45, probably not a couple of you there, but so this might be something to be thinking about. Of all people that use a stool test, a screening test, probably about 10 to 15% will have a positive result. A positive result doesn't mean, yay, you're free to go. A positive result means you've actually got a bit of blood in the stool test. But doesn't mean that that leads to bowel cancer. So if you have a positive bit of blood in the stool, there's probably about a 1 in 20 chance you might have a polyp, a benign growth. There's about 3% chance that you might have a bowel cancer. But hopefully, because you haven't had symptoms, because this is a screening test, you shouldn't be having symptoms, we've picked it up early enough that it can be curable. The bowel screening test, if you haven't ever done it, is 2 stool samples on consecutive days. We do 2 samples because we know that bowel cancers or polyps, which can also give a bit of blood, don't necessarily bleed every day. So that increases the pickup rate. And if you're doing that every 2 years, that pickup rate is getting so close to 100%. Unfortunately, though, it isn't 100% at this stage. And then once you've had, if you do have a positive stool test, then yes, you do need to, or should be referred on to get a colonoscopy. But we also need to reduce our modifiable risk factors. So alcohol in moderation, okay, and trying to stick with those guidelines of less than 2 standard drinks a day. Smoking, no smoking is good, so reducing the smoking in as much as you can, but the optimal is to stop completely. Exercise, there actually is evidence that regular physical activity reduces your risk of bowel cancer by about 15%, so 30 minutes a day regularly is what we aim for. Optimal weight, having a normal waist circumference and then within the normal weight range reduces your risk. Diet, we've already talked about red meat, we'll forget about tonight, but trying to keep it at a minimum to at least no more than 4 serves a week and keeping preserved meats at a minimum. There is also evidence behind plenty of fresh fruit and vegetables in your diet preventing bowel cancer and a good intake of dairy. So doing all of those things. Now I talk about gut health quite a bit, and I know it's not everyone's cup of tea and it's probably bores a lot of you. But there's so much information out there, isn't it? So on one hand, I tell patients, you need to increase your red meat intake because you're anemic and you've got low iron. And then I'm telling you, don't have red meat, but stay away from preserved red meats because it's increasing your risk of bowel cancer. I'm telling you to stop drinking alcohol, and then on sunrise they're saying, well, actually red wine's good for you, and then coffee's good for you, but then it's not, and it can be a real minefield sometimes. So that the second part of my talk is talking really about gut health and what you eat, and really about our microbiome. Whatever we put into our mouth, whatever we do to our bodies is going to affect our health to some degree, whether that's good or that's bad. It's always going to have an effect. And some people need to make specific changes to better their health in terms of what we eat for their gut health. So for example, someone with celiac disease has an intolerance to gluten, and so they are better off avoiding gluten in terms of their symptoms, but their overall general health. People that are lactose intolerant, that have maybe diarrhoea with lactose, should, if they want to, avoid lactose to avoid having their symptoms. But for the general population, sometimes it can be a bit of a minefield about what to do and what not to do. With our microbiome, when I'm talking about that, I'm talking about the trillions of bacteria, fungi, and viruses in our gut. They reside anywhere from our mouth right through to the anus, but usually they live in the large bowel. It's quite acidic in the other areas of our stomach and our small bowel. And if we had to look at how many cells this microbiome takes, it's about 50% of our whole body cells are made up just in our gut microbiome, which I think is amazing. Maybe you don't share that with me. We develop our microbiome actually when we're in utero, so in the mother's uterus, and then the first year of life it really mimics the mother quite identically. But obviously factors like the foods and environmental exposures then start to change that, and you've probably fully developed your microbiome by about the age of 3. Obviously the microbiome is going to fluctuate throughout your life depending on the foods that you eat, diseases, medications, stresses, and a lot of different things. And we often think, as I said before, about the foods that we eat changing that microbiome, the good versus bad bacteria. One day we will be able to give a stool test that can print out exactly what thousands of levels of different bacteria and gut fungi and viruses, and then print out exactly what pill you need to take to fix your microbiome, but we don't have that at the moment. So diet is the best thing that we've got. And it is really important not only for gut health. A lot of research shows that the gut microbiome has a lot of effects on our other bodily systems. So our immune function, cardiovascular disease, mental health, so linked to depression, and also linked to diabetes. Linked to obesity. So it is extremely important. If we had to look at generally what the best optimal diet that we would advise for the general population, it's probably the Mediterranean diet. So plenty of fresh fruit and vegetables, nuts and seeds, legumes, some white meats, but minimal red meat and processed foods and processed meats. And so that would be sort of the most optimal diet. But really, it is quite confusing, and it's changing every decade. And I wish I had the link that I could find. There's a video of a couple doing a bit of a skit over the decades eating eggs and bacon. And, you know, the first decade they eat eggs and bacon because it's really good, you know, strong protein, gives you energy. And then the next decade she takes the eggs away because eggs are bad for cholesterol. And then she gives the eggs back but takes the bread away because it's gluten intolerance. And it is quite funny because our research is ever evolving and things are changing. But I think just a well-balanced, everything in moderation approach is probably the best approach we have, and not cutting out certain food groups unless it's specific to you is probably the most ideal diet. So I'll leave you with this one because you're all nodding. You know what I'm talking about. But yeah, that's the end of my talk. I will introduce the next few speakers shortly. We'll probably have about a 5-minute break between mine and the next speaker. Then we'll have a half an hour break and then the final 2 speakers. So you've got time to go and get a drink. But does anyone have any questions about bowel cancer or gut health?
What about hot foods?
Yeah, not specifically. Yeah, not you're talking about spicy food. Yeah, not causing, you know, damage specifically to the cell's DNA and causing cancer. It may cause symptoms for certain people, but no research to show damage. Yeah. Yeah.
So is there anything specific we can eat to improve our gut health?
So I think coming back to plenty of fresh fruit and vegetables and a well-balanced, like the Mediterranean style diet. Yeah, so there's a lot of evidence behind that in terms of the gut microbiota. Still, the research is out in general, you know, to give us specific guidelines, but it is thought to be beneficial. Whether it's for some people then causes symptoms of sort of more of an irritable bowel sometimes, that might be the case.
All those tablets with little, billions of in each capsule.
Yeah, like probiotics and prebiotics and postbiotics, and I think they're on the right approach. They do have the right idea about promoting good healthy gut bacteria, but we're talking about 40 or 100 strains, and in actual fact, in real life, we've got over thousands of strains, and the proportions might be needed to be tailored to individuals. So it might work for some person, but then not for the other. So why is it different? So the right idea, and for those that it does work, then that's great, but it isn't for everyone. Yeah. Good. All right, have a quick 5-minute break while we load up the next talk, and we'll keep going.
I have so many fond memories of the Mid-North and Melrose. We've had a great trip here. I used to be a medical student in Clare. And in fact, the very reason I became a urologist is because I sat in on Kim Peasy's clinic in Clare. Some of you might know him, he's an old Clare boy. And he had 3 men come in that morning with prostate issues. And I was sold. I'm like, this is the best job in the world. So here I am talking to you guys, and I have the great pleasure of continuing to work with Kim in public and private practice now. And I guess just to add on to what Alice was saying, it really brought home to me, my dad had bowel cancer when he was 46. So I was a medical student and we'd gone on a holiday, and I remember on this holiday he said to me, Soph, I'm farting more, is that normal? And I thought, we're on a holiday, we're in Greece, God knows what you're drinking, that's normal. And we got home and he had a show of blood in his stool, and he went to his doctor and he was diagnosed with bowel cancer and had surgery and radiotherapy and chemotherapy all really quickly. And he's still with us now. It's almost 20 years and he's doing really well. So it's well worth just anything you're worried about. You've got Alice here. It's easy to get a checkup. So is there a clicker? Or you've just been pressing? Yep. So tonight I'm going to talk about prostate cancer, and I'm going to talk about incontinence, and plenty of time to ask any questions. It's a really interesting topic. Obviously I've dedicated my life to it. So what is the prostate? Everyone always says, what is this thing? And was it always there? Why is it giving me trouble now? So the prostate was always there. You were born with it. And when you're born, it's really small. It's kind of the size of a walnut, and then it grows. And it's a natural part of aging that this gland gets bigger as you get older. So it kind of stays a normal size until you're about 50. And then once you turn 50, all that testosterone in your body makes it grow bigger, and it starts causing you problems. It causes either cancer, or it gets really big and it might cause a blockage and you can't pee very well. So it's a natural part of aging, unfortunately. And what's its job? The main job of the prostate gland is it's kind of the epicenter of your downstairs. So it creates and it makes all of that fluid that's in your ejaculate, and it blends that with the semen, and that's what it does. So it's really important in terms of reproduction. And then, you know, once you turn 50, 60, it just causes you trouble. So we're very grateful to it, but it's a bit of a naughty organ. So prostate cancer, the main way we diagnose it is actually from a blood test. So men will go and get a blood test, and you should get them from when you're about 50. If you've got a family history, so if someone in your family's had prostate cancer, you should be tested from about 45. And it's once every 2 years. So your GP just adds it onto a normal blood test. Now, important to mention, we're in Melrose. So the sorts of things that make your PSA go up normally is infection, so urine infections, cycling. So if you like cycling, just hold off for a few days before your blood test. Any sort of sexual activity will actually cause it to rise. So again, you've got to hold off a few days before your blood test. But that's the main way. The other thing is, a man might come to us and say, look, I can't pee very well, it's kind of been changing, I'm up all night. And that's usually not cancer, but occasionally it will be cancer. So the prostate getting bigger because of cancer. And very rarely, a guy might come to us or see their GP and say, I've got pain in my shoulders, pain in my hips. They get an X-ray, it's not a fracture, it might look like cancer. This is rare these days, it's really rare, but it might be that we don't diagnose it until it's spread outside of the prostate. So they're just the things to keep in mind, but the most common is the blood test. How do we investigate it? The GPs do the blood test, they send you to a urologist. So you would see Kim if you were seeing someone in Clare. There's a urologist who goes to Port Pirie, Port Augusta and to Whyalla. They would send you along, you'd get an MRI scan, and then we do prostate biopsies. And I think each and every one of those sites we can do the prostate biopsies. Now you have a general anaesthetic, you're out to it, you're not aware. The MRI scan, you go into a tunnel, I've got a picture of that. That's the MRI scan. I think the closest one here is in Elizabeth. And you get that scan done. It'll take about a half a day by the time you get there, sort out the scan, come home. And that scan gives us these beautiful pictures that really show us if there's an area in the prostate that looks like it might have cancer. So when we do the biopsies, we can take biopsies of these shadows. So there's this sort of shadow here that corresponds with a black point there. And we'd say, okay, we'll take some biopsies from that area, but then also we take biopsies from other parts of the prostate. So the procedure takes about 15 minutes. You'll have some blood in your stool and in your pee for a couple of days. You'll have blood in your semen for up to 3 months. That's normal, because remember what the prostate does? It creates all the fluid, so it's going to keep flushing it out. But that will all settle. So prostate cancer, like bowel cancer, when you find it early, although it's a bit of a bother that you might need to have treatment, it's actually life-saving. Like, we can cure it. And most men in Australia, it'll be caught at a point at which it can be cured. So 95% of men will have a cure at the time that they're diagnosed. If you've got low-risk disease, we now know that we actually shouldn't touch you. No surgery, no radiotherapy, nothing. You should just have a blood test every 6 months or so, maybe an MRI scan every couple of years. Because of those men with low-risk disease, like 60% of them will never need treatment in their lives. It will never grow, it will never change, it'll just stay like that. So in those men, we don't touch them. 40% of them, it might grow and change and they need treatment, but 60%, nothing. So a very hands-off approach for those men. There's an intermediate risk group. Most men are in that intermediate risk group, and those are the men who should have treatment if they're going to live another 10 years. So for us, our screening cuts off at 75, like the bowel cancer screening, for that reason. Because if you're 85 and you've got intermediate risk prostate cancer, well, we should have never done the test. We should have never done the biopsy. You should never know about it. It's not going to bother you. But if you're 65, it will make a difference. We should treat you at 65. At 75, then we can have a negotiation about if we treat you or if we just delay it and see, you know, if it grows, then we'll treat you. If it doesn't grow, we'll just leave it. So there's a lot of room for negotiation. And then you've got the high risk group. And unfortunately, these men have a more aggressive tumour, or it might have spread outside the prostate by the time we diagnose it. In those men, we need to treat them soon, and there might be a group of treatments they have. So they might need some chemotherapy, they might need hormone treatment, because prostate cancer is a bit like breast cancer. So breast cancer is driven by female hormone, prostate cancer, it's driven by male hormone. And we treat that with injections in order to dampen down the testosterone that your testicles make to stop the growth. And some men might need some radiotherapy. So I guess if we're talking numbers, in the population, 1 in 5 men will have prostate cancer. And of those 1 in 5 men, so this is all men up to the age of 100, and of those 1 in 5 men, probably about half of them, maybe just over half, will need treatment. So in the long run, lots of men will have it, but not all men are going to need treatment. So the monitoring, I just came back from a meeting, a European meeting, which was really interesting, because what they're trying to push now is that even for more of those men with that medium risk group, that we don't treat them until a lot later. And in Europe that makes sense, because they've got so many patients, they're trying to save money and limit treatment as much as they can. And I think that's going to start happening more in Australia too. But as I mentioned, those low risk guys, we do what we call active surveillance. So that's a combination of MRI scans, blood tests, and maybe repeating the biopsy every 5 years or so. So it's not too much there. For men with the intermediate risk, so when we say, look, you need treatment, it doesn't have to be tomorrow, we've got time to think about it. For those men, we talk about a prostatectomy where we remove the prostate, or we talk about radiation therapy. And the choice of that depends on the man. It depends on his level of activity, his age, his health, his location, and how we think he might cope with surgery. So how many men in the room would know someone who's had prostate cancer and maybe had surgery? Yeah, everyone, that's it. You've had prostate cancer?
3.5 weeks ago, I had a radical prostatectomy.
There we go. There we go.
I was Gleason 3-4.
Yep.
I was given a choice of a bit of active surveillance or radical prostatectomy. I'm 50 years of age. They were able to say it was right in the biopsy had located it in both sides of my prostate, but it was nowhere near nerves or any of the rest of it. And I was given the choice of a bit of active surveillance or do something now and get rid of it. And I was just like, let's do it. So my urologist is Urological Solutions.
Oh yeah.
Dr. Alex J removed it, and Dr. Kim Paisley was my. This is not staged, by the way. And you were like, I was like, Urological Solutions.
That's right.
So Kim Paisley was my urologist.
Yep.
And I'll tell you what, he's about the worst bloke I can ever. He's a glass half empty kind of bloke. He is shutting the door and he's walking to his seat and he tells you you've got cancer as he's walking to his seat like, there's no holds barred with that. But actually, like that about him, because I'll tell you what, he's as straight as a die.
Yeah.
Kim Paisley is actually my urologist. Dr. Alex J removed my prostate 3.5 weeks ago.
Yep. And you've catheters out?
My continence is 100% since day one.
Fantastic.
I wouldn't say let's say everything's improving down there. I'm on a few tablets and stuff, but it's only going back there now.
It will. It will. Yep.
It's like sleeping on your arm and you wake up and it's like, oh, it's a process. You know what I mean? I knew it wasn't going to get right back there immediately. It's getting there.
It will. It will. And look, you're the perfect case study. That's it.
Yeah, so I know where we're coming from. I've been there 3.5 weeks ago. So.
That's it. And he lives to tell the tale. Look, that's fantastic, and that's best of luck with your recovery. I think you were right to take it out now because it had to come out at some point at your age. You know,
Absolutely.
it was going to come out. You know, you're healthiest now than you are going to be in 5 years, and your chance of having cure and getting your erections back is much higher now than it would be later. So that's great.
I had somebody that I spoke to a while ago said to me, right, his brother and him had prostate cancer, and two of them done two separate things. If you go for a full prostatectomy, you're at your lowest point and things only get better.
That's
if
it.
you go for that
Radiation.
radiation, you know, radio beam, whatever. He was really good for 3, 4, 5 months, and then everything started to go downhill, and he didn't know where that was going to top. That's not to put anybody else off. I'm just saying to you, if you have a clear gap to everything else, you know, things are going to be different, but, you know, make that decision, just get it out of there, like, well, that's my opinion, I think.
Look, I agree with you. I think all surgeons would agree with you, but you've got to make the decision for yourself, and you've got to own that decision. You know, it's my decision, it's what I'm going to do. So, you know, we've talked a lot about surgery, and if you've got private health insurance, and look, even for most of our public patients now, you can have it done with the robot. That's overnight surgery. It's a catheter in for a week, maybe 2 weeks. It's a good operation, and it's only an operation that's been around since the 80s, so we've been perfecting it for the last 40 years. Radiation therapy, there's loads of different ways that they can deliver radiation therapy, and then hormone therapy is just for a select group of men. So just to recap, treating it early increases your chance of cure, diagnosing it early increases your chance of cure. If it continues to grow, so let's say you leave it, it might spread outside the prostate, but the prostate can get bigger and it can cause you more trouble when you try to pee. So eventually it'll start causing you issues, which is why it's nice to just, you know, nip it in the bud. And when I started training, so when I met Kim Paisley in Clare and I started training with him, we would tell men 50% chance of living in 2 years if you've got prostate cancer in your bones and outside your body. That's blown out of the water now. There are so many treatments. We're seeing these men live 15, 20 years of good quality life. So it's very, very different. It's changed very quickly. So I've just got a few slides on incontinence, and then I'll leave you to your break. With incontinence in general, so it can occur after surgery or radiation therapy for prostate cancer, but it can occur in men who don't have prostate cancer because they might have a blockage in the tube that leads from the bladder to the outside world, the urethra, stricture we call it, or if the prostate's grown bigger and it's blocking the bladder and the bladder's not emptying very well, and you get what we call overflow incontinence, which could be a bit of a dribble. That then causes back pressure up to the kidneys. Kidneys go into failure and shut down, so you almost get worse side effects from that than you do from cancer. So I see a lot of men and women with incontinence issues. With men, it's more men who have had surgery and prostate cancer treatments, otherwise men with enlarged prostates. And so what we're looking for any cause of blockage down that tube there, so whether it be the prostate, whether it be the narrowing there, whether there be stones sitting in the bladder, lots of different things can go on. And there are some very simple procedures and even tablets that can make your life a lot easier. What we do know is that if a man doesn't empty his bladder well, so this is your normal barn door man without prostate cancer, if you're not emptying your bladder completely and you're leaving 200 mils, so like a cup's worth, behind in the bladder after you pee, 1 in 4 of those men are going to end up at the Boolaroo Centre looking for a catheter at some point in the near future, and especially if they've been on the booze one night. So these sorts of things just happen on a day-to-day basis. So if you're feeling that you're not emptying your bladder well, see your GP. They can organise an ultrasound scan. It's not urgent, but at some point you need to know, are you emptying your bladder well? Is your kidney function okay? Because those things can be fixed with some very simple procedures, if needs be. So if someone comes to see me with an issue emptying his bladder, he gets a cystoscopy. So where's Alice's scope? A bit like this. It goes up the front passage though. And most men don't have that with anaesthetic, I'm sorry, but it's a bit smaller. And then if you need, some men will get this treatment called urodynamics. So it's where I put a little catheter in the bladder and one in your bottom, and I measure your bladder pressures, and that just helps me work out if it's a bladder problem or a prostate problem. And then from there we sort of choose together what your best treatment is. Tablets is where we start for most men. Some men and women will need a bit of a bulking agent. So you think of lip fillers, you know, the Kim Kardashians of the world, all those people in the magazines. Instead of putting it there, we put it in the urethra. We put a sling sometimes in the urethra. And sometimes we have this little pump that we can put in as well. Again, that's really for men who've had prostate cancer where their incontinence might be bad. And that's me done. Thank you for your attention. Any questions? And thank you very much. What was your name?
Billy.
Billy. Thank you very much, Billy, for your input.
Just on the PSA test,
Yeah.
how reliable are they? 100% reliable are they? Or are they?
Look, they're pretty good, but there's lots of things that aren't prostate cancer that can cause the levels to go up. So we usually do 2. So before we decide to do an MRI or biopsies, you'll have them done 3 months apart. And if they're still up, so after whatever has happened to cause the first one to go up, we give it time to settle down. If it's still up, then you earn yourself the rest of the tests. But, you know, some men might have a PSA, so we test from about 3. Some men come to see us with a PSA 50, and that might be from infection. It's not even from cancer. So things that aren't cancer can cause much higher levels than cancer can. No worries. Any other questions? Stunned silence.
Is sex report or not?
Look, sex for the test is not great because it'll drive the levels up, but otherwise, absolutely, it's absolutely fine. It won't increase or decrease your risk of cancer. Unfortunately, I don't have any tidbits, so I can't say that alcohol or anything other than being male increases your risk, so keep doing you.
Sophie, what about rectal examination? I don't know whether I saw it on your slide.
Yeah.
Do we do those, do we recommend those for men anymore?
We really don't. So in the primary care settings, that's with your GPs, the guidelines have taken out the rectal exam. Because we find that the PSA, you know, more men are happy to have a blood test than they are to have a rectal exam. And if your rectal exam's normal but your blood test's high, you should still go see a specialist. And look, we were talking about it at this meeting, and as specialists, most of us, if we've got a guy who comes to see us with a high PSA, most of us don't examine you and check your prostate when we meet you because you're going to have a biopsy. We'll check it at the biopsy. We'll do an MRI scan. The men who we do test are the ones who come to see us who have trouble emptying their bladder, and their PSAs, the blood test, is kind of in the normal range or a low range, because you don't want to miss that small group of men who have a normal prostate but have prostate cancer. So they're the men that we will check the prostate if they have symptoms, but men who don't have symptoms and just have a blood test, you can avoid, I think in general you can avoid the finger test, and that's been out of the guidelines now for a couple of years. But you should have a blood test. They took it out of the guidelines for a few years. It was chaos. It's back in.
How much does genetics play a part in that?
It's important, absolutely. So if you've got a family history, we say to get tested from at least 45. So it's only the normal, so people without a family history test from 50. If you've got a family history from 45, and I'd say family history is, you know, anyone in your family maybe over 65 who's had it. I'd say anyone under 65, we'd start to think you were more in the high risk group. But they say, you know, you need 2 first degree relatives, all very complicated. So I'd stick to 45 or 50 and just go from there. Billy, any comments?
No, my father had it at 55.
Yeah, so you got
My grandfather had it at 66. It was only whenever my dad had it at 55 that my grandmother told my dad that his dad had it 10 or 15 years earlier. They kept it a secret.
Yeah.
So when my dad had it at 55, I was probably 28, 29. I've been getting a PSA done since I've been 40 years of age. It's been sitting about 0.9, 1.1. I'm a bike rider, you know what I mean? So I'm not really stopping riding bikes. So it's going up and down a little bit. At 48, it jumped to about 1.5, 48 and a half, 2. 49 was about 2.5. This was Dr. Paisley's looking after me. 49 and a half was 2.9ish or something. And he said, right, get it done in 3 months' time. Now, Dr. Paisley he's got big fingers, man.
He does.
Probably 4 to 5 times. I'll tell you what. I absolutely thank that man for it. He looked after me really well, right? He's had MRI done on him. When I had my staging done, he's done extra. He is an absolute legend in neurology. But what I'm saying to you is right that as soon as it went 3.4, and I was 49 at that age, that was outside my range for being whatever 40 to 49. He was like boom, straight Flinders for a biopsy.
Yeah. And the first guy.
Tennyson Centre, it's a good spot to go if you've got issues like ortho. If there's and I'll tell you what, don't downplay them either. If your doctor says, you know, blah blah blah, you know, it's only this year, is there any, maybe play it up a little bit. It can actually be a good
Sometimes
thing
you need to push the point. Yeah.
So, absolutely. PSI, get it checked with your urologist.
The youngest guy I diagnosed last year was 46 with a PSA of 7. So his blood test was clearly abnormal, but his GP should never have done that blood test. We were just lucky. Yeah. Well, thank you so much for your attention, and we can have a chat later. Thank you. Oh, I turned it off. Sorry.
Okay, well, first of all, thanks for having me, and hats off to Alice. It's one thing to throw some money in for a good cause, but it's another thing to invest so much time and effort into it and get a group of blokes into the same room, which is a pretty hard thing to do when we start talking health. I suppose, contrary to the other couple talks that we spoke about before, mine's probably a little bit broader. There's lots of different types of joint injuries and bits and pieces that can go on. I'm sure, and it's probably, I don't think too many people in this room would have been immune from one at some point in their life. I know I've done my fair share. And of course, we've got a very broad audience here as well. So we'll be covering a fairly broad overview of joints. Okay, please feel free to ask any questions as we go. Billy's nicked off, so I was counting on a couple questions there. Yeah, feel free to throw some questions out. Okay, so basically the joints, what are they? There's 3 different types. There's those joints that are fused together, so like your cranial joints that fuse together early in life. They're the fibrous joints. The next type of joints are your cartilaginous joints. They allow a little bit of movement, so that might be around your sternum, at the front of your pelvis, down through your discs in your spine, where it's a piece of cartilage that is connecting 2 bones together. I'm sure we've all done some damage to those before too. And then the third and the most plentiful type of joint in the body is your synovial joint. So that's the ones that you guys would be most familiar with. They're the freely mobile joints, so the ones in your hands, knees, ankles, hips, shoulders, and right throughout your body. Okay, and they've all got some common characteristics. And so, for example, you've got your synovial cavity. Now, that's the gap between the bones, okay, where all the fluid and the other bits and pieces sit. You've got your joint capsule. That's like a Woolies bag that wraps around the joint to keep the fluid in, a milky fluid. It's a bit like whisked egg whites. And it's quite a milky fluid that provides lubrication to the joint, but it also provides the nutrition to the joint, and there's also factors in that fluid that clean your joint too, okay? And there's kind of 2 layers to it. There's the outer layer that has all the ligaments wrapped into it, so it's kind of like a structural layer, and then there's the inner layer that actually helps release some of that fluid, okay, that controls the release of it. Then you've got the articular cartilage. Now this one gets all the airtime, doesn't it? You know, we all know about arthritis, and there's lots of different things you can do to that. But that's obviously the smooth surface, which reduces the friction of the joint when you're moving it, okay? Now the other bits and bobs that you've got in there, most of them have some or all of these. You've got the cartilage discs or menisci. Now if I weren't holding this, I'd be able to show you a little bit better. But the menisci is the blue thing in between the knee here, okay? That's the cartilage disc in between the knee, okay? And you might have already had a meniscal tear in your knee or know someone who's had one, especially those people who play those land and pivot type sports. And basically they have a couple functions. One is as a shock absorber, and the second thing is, much like in the knee, these little blue things are like egg cups, okay? So they hold the rounded part of the bottom joint in congruent with the joint below, okay? Then we've got fat pads. Now that's kind of like the cushioning around the joint. Their only real function is to reduce shock to the joint. For example, if you were to kneel on your knee or take some trauma. Tendons and ligaments. Now, does anyone know what the difference between a tendon and a ligament is? Or brave enough to actually say it? No? Well, your tendons attach to your muscles, okay? That's the way that your muscles attach to bones, okay? And ligaments attach bone to bone. So your ACL in your knee, for example, would be a ligament because it's attaching bone to bone, whereas your hamstring tendon would be the thing attaching the muscle belly of the hamstring to the bone, okay? And you can obviously get injuries to both, and we'll go through that in a little bit. Bursa. Anyone heard of bursitis? It must be the Oscars. Bursa, they're fluid-filled sacs. They're a bit like a ball bearing, really, although they're not as hard, that acts to reduce friction between tendon and bone. So, for example, your patella tendon here has a bursa underneath it to prevent the patella tendon rubbing against the bone underneath, okay? And many of you may have heard of hip bursitis. That's where some of your hip muscles, where your hip muscles are separated from your ilium of your hip by this bursa to try and reduce friction, okay? Then we've got the synovial fluid. Now this is good stuff, okay? This is the fluid in the joint that to a large extent controls the health of the joint, okay? And like I said before, that controls the nutrition within the joint, controls some of the shock absorption within the joint, and it controls the cleanup of the joint. Okay, I just wanted to throw this one in there because there's a real sacrifice in some of the joints between mobility and stability, okay? So anyone know what this one would be a x-ray of on the right there, or my right? That is your shoulder. And you'll notice that this rather large ball sits on a very shallow plate. That's meant to be a cup. It's a ball and socket joint. So in this situation with your shoulder, you're relying on a lot of ligaments, muscles, etc., to maintain the stability of that joint. Okay, and that's why we have a lot more injuries in the shoulder than what we do in this one. Does anyone know what this might be? That is a hip. Okay, you can see it's a much deeper socket. And a much deeper ball and socket joint. So you've got a lot more stability there, but of course you can't move your hip as well as you can your shoulder, okay? So this one has got a lot more anatomical sort of stability, and the other one relies on some of the structures around it that we said about before. Okay, what can go wrong? Well, a fair bit, and I'm sure we've all experienced it to some extent. So I'm just going to go through some broad obviously we're trying to serve the masses here a little bit, but I'll go through some broad things that can go wrong in these areas, and then next we'll talk about what you can actually do about it, okay? So with the articular cartilage, the most common one we would know about is arthritis, okay? Now there are hundreds of different forms of arthritis. Some are due to wear and tear over time. I'm sure we've got some footy players in the group, and cricket players with that landing foot. And so you can get over time some wearing down of those surfaces. But there's also forms of arthritis where the body, like autoimmune type arthritises, that actually get the wrong idea and start attacking the joint. Okay, so your cells start to turn on themselves. So there's different treatments depending on what type of arthritis, and I won't have the time to go through even one spec of the type of arthritis tonight. The other thing that you can do in young people, you can actually get some peeling of the cartilage off the bone, okay? It's got a really long name, and you will see that sometimes in young people, okay? And you'll get catches of the joint when that's the case. Fractures, there's lots of different types of fracture, but in concerning joints, there's probably two main types that you need to know about. One that actually goes through the articular cartilage and can cause some issues going later on, and some that are either below or above the joint line, which do tend to heal really quite well with a pin or conservative management. Ligament tears. Who in this room has done their ACL or their PCL in their knee? Normally there's a couple. 1, 2, 3, 4, 5. Well, you'd be interested to know, and I was going to save this for the next bit, but recent studies have shown that 58% of people, 58% of ACL injuries will spontaneously heal when they've had an MRI after 5 years now. So there's a different tact in how we deal with ACL injuries these days, because we know now that they have the capacity to heal rather than jumping in on them straight away. Okay, so if you are Roden playing for the Crows, who had that Lars surgery, yes, you're probably going to get the operation straight away, so you can jump back straight into sport. But if you jump off the back of the ute and you hurt your knee, you do now have the option of going the conservative route. My brother did exactly that. Yeah, so ligament tears, tendon tears, so that is, you would have heard of those grade 1 through to 3 of either the muscle or the tendon that attaches to the bone. Normally when we're talking about ligaments and tendons, grade 1s are a slight tear of the tendon or the ligament. That might be a 2 to 4 week injury, not a lot of loss of function. You can play through them with sport with some taping if it's grand final day. Then you've got your grade 2s. Your grade 2s are a fairly significant tear. It can be right up to 95% tear of the joint, where you've got very significant loss of function of the tendon, and you'll be looking at somewhere between a 4 and 12 week recovery time, depending on how much you've gone through it and what tendon it is or ligament it is. And then of course you've got complete rupture. Now complete rupture once upon a time, like I said before, largely always meant surgery. Now we know that we can, with maybe immobilisation or with some bracing or with time, you don't always have to go the surgical route. Okay, so take some I guess some gusto out of that. So infection, generally infection, you can get infective arthritis, but generally infection only occurs once someone has entered the joint, okay? So that would be generally with the orthopaedic surgeries, where they go in with arthroscope, or they've done a total knee replacement. So that is a risk, obviously, of surgery, and another reason why sometimes it's worth considering conservative management first. Cartilage disc or meniscal tears. Quite often that is, for example, if we're talking about the meniscus in the knee, those land and twist type injuries where you might either split off a little tag or what they call split it down in the middle, a bucket handle type tear, where they might either leave it completely if it's nothing significant, they might go in and sew it up, or they might clip it off altogether. Very poor blood supply to the meniscus, so the surgical route doesn't tend to have that greater incidence, so only get it done if you absolutely have to, okay? Tendinopathies, that is where the tendon, so that's where the muscle attaches to the bone, gets very grumpy, okay? And then we'll have to look at the reasoning why that is. Generally, it's because we're using our body in a way that it's not used to working. So for example, if you decided that you wanted to run the City to Bay next week and thought you would do a 5K run tomorrow, your tendons aren't going to be too happy about that. However, if you were to decide to work up to walking 10Ks and then slowly, part run and slowly build that up over the next 3 months, your body would have probably no issues with that, okay? So generally we get tendon injuries when people jump into things a little bit too quickly. And the bursitis is the inflammation of that little bursa that we're talking about before, those fluid-filled sacs that are between the tendon and the bone, okay? So you end up with something called bursitis, and there's a range of treatments we can do to help that as well. So what do we need to know? I've tried to keep this short and sweet and keep as few slides on the on here as possible. So knowledge is power. What I mean by that is if you understand what's actually going on in your joint and how they work, what things you can do to keep them healthy and what happens if you don't, well then you're more likely to look after them. And you may need some advice if you're currently going through something or if you want to look after your joints going forward. So knowledge is power. Learn about your joint if you are worried about something and we can help you do that. Graded return to activity, well I've just given the example before, and that's not just the case in individuals that have been doing absolutely nothing and want to jump into something completely new to the body. It's also important for those people that play footy for 8 months of the year, sit down and play video games or drink wine and have cheese for the other 4, and then decide to jump straight back into footy again. That first pre-season, I think most coaches take a lot of joy out of what they can put you through in that first session, but often it's at the detriment to yourself. So graded return, okay? So you need to grade yourself in, and that's the case either when you want to do something new or when you're returning from injury, okay? And again, common sense does a lot of help there, but you can also get help from professionals there too. Now, has anyone heard of RISA on your left of screen there? So that's the rest, ice, compress, elevate sort of thing that have been pushed for ever, okay? That has changed in a big bad way in recent times. This is the new acronym that you have to put up with, love and peace, okay? Now, I'm not sure whether I agree with Sports Medicine Australia on this one, because RICE worked well because people remembered it. And I have trouble remembering what all those letters stand for in love and peace. But just to go through it, this is what is recommended for joints when you're dealing with an injury, okay? So this is really going to put me on the spot, but load, okay? So L stands for load. You're going to have to reduce the load on that joint initially to allow it the opportunity to heal. But that doesn't mean remove load altogether. O is optimism, okay? Now there's been, I know it's very fluffy, isn't it? But optimism, there's been lots of research recently around the links between the brain and the amount of pain that you feel and the ability for you to get back to sport, and how your brain impacts those healing factors around your joints. And so that we do see a lot of people that come in now with Dr. Google that come in feeling quite catastrophic about their injury, and it does actually impact your heal time, believe it or not, okay? So quite often it helps to be optimistic and know that almost all tissues in the body will heal if you give it the opportunity to do so. V stands for vascularisation, okay? Vascularisation means get on, if for example a knee injury, get on your bike, okay? Get on your stationary bike. Vascularisation means do some aerobic exercise to start getting the blood flow back again, okay? E stands for elevation. There actually is, the reason why RISA is now love and peace to some extent is because there is zero evidence for ice, out there now, zero evidence. It's thought that what it actually does is halts one of the body's natural processes. There is a reason why inflammation gets sent to the joint, and there is a reason why the body has to go through that process to both protect the joint, get rid of some of the nasties that are like the debris around the joint, and then start the healing process. So when we start using anti-inflammatories and using cold packs, we actually halt the healing of the joint, believe it or not, okay? So ice, no evidence for it, unless you're using it for pain management. I've always found it makes it more painful, to be honest. And E, elevation, not much evidence for elevation either, but it can help deal with the severe fluid that you can get in some of those joints, okay? And of course, if you're elevating, ideally you're elevating above the heart, okay? How can you do that with something in the lower limb? You recline or lay back, okay? Peace. P. I'm just trying to think what that is. Protection, okay? Protection. So that is, for example, you wouldn't head back into a trauma-based sport. You would put, you may need a bracing or taping in place to support it. E, where are we at with this? I'm trying to remember what they are now. This is a relatively new acronym. Yes, please do. Educate. Educate, okay, so of course people need to know about their joint. A, what are we at with A there? Alcohol. Yes, that one is not overly helpful. Anti-inflammatories is A. Anti-inflammatories. So it's thought that anti-inflammatories actually impact the healing process as well. So now they are not necessarily recommended because they halt the normal healing process. Where are we at with C, Mads? Compress, okay. Now compression, again, there's very little evidence for compression, but a lot of people find it comforting to have it in place and it doesn't do any harm. Okay, so some of these things still remain in there, for example, elevation and compression, because they do no harm and they might help with your painful symptoms. And E, believe it or not, is exercise. Okay, so it is So if you take us, a couple thousand years ago, we didn't have the opportunity to sit down and be waited on and have a ready access to food. We unfortunately, when we rolled our ankle, had to get up and keep moving, and the body has adapted to be able to do that. So you'll notice after joint surgeries, for example, they would have had you up very early on after the surgery itself. And it's the same thing for an ankle, knee, hip injury. They'll get you up and moving really quickly. We were talking about that synovial fluid in between before. That, if we're not regularly splashing that around the inside of the joint, you're not getting nutrition to the inside of the joint, okay? So it's actually really important to get that vascularisation, that movement, and that exercise in relatively quick. Now, you probably may need some advice depending on the the injury that you've done as to how quickly to do that. I'm not saying to jump straight back on the bike and hit the trails the day after, tearing your ACL, okay? But yes, that's what's recommended. Exercise versus surgery. There was an orthopaedic surgeon who had to have a knee replacement. He didn't want one. He'd done them on lots of other people and knew what sort of garden tools were used in that process. And don't get me wrong, there are definitely places for orthopaedic surgeries. But they then did a study of an exercise intervention compared to the orthopaedic surgery and found about the same result. Now, what the main findings of the study were is that it's worthwhile going through a conservative management treatment first, and then the ones that don't respond well to that, providing that you stick to it, can then move on to the surgery afterwards, okay? So don't be so quick to go under the knife. You may not have to, okay? Static versus dynamic warm-up. Now, the static exercises, for example, are the stretches like this. Again, almost no evidence for static stretches, okay? We've done them all our life, and this evidence has been in place for 10, 15 years. We're just starting to catch up on it now. The only time it has a place is, for example, if you've had a joint immobile for a long period of time and you need to get the range of movement back again. But as for before sport, what they really recommend is the dynamic warm-up. And we're doing that as well, to be fair. So that's your run-throughs, that's your small kicks, that's your side steps, walking backwards, all of those sorts of bits and pieces that you're mimicking basically what you're going to do in that sport. And if you're thinking about what is an effective warm-up for sport, you don't need to be a physio to work that out. You just need to break down what you're actually going to need to do within that sport itself, and do those movements prior to ready the muscle for that event, okay? To brace or not to brace, quite often we get asked about taping and bracing with any number of injuries, whether it be arthritis or an acute injury. Taping and bracing is really good for the return back to activity. For example, the taping of the ankle after you've rolled it when you're wanting to get back to sport. However, if you're taping at all wakeful hours or bracing at all wakeful hours, it actually has the opposite impact, because you're doing some of the job of the ligaments, tendons, muscles for it. And so if you ever were to remove that brace, your knee or hip or whatever brace you're using would actually be in a worse position than prior, okay? So they are great for weaning back to activity, but we wouldn't often recommend that you wear them at all times unless you've tried everything else and it's the only way to stabilise the joint without surgery, okay? Pain sciences, we kind of touched on them before. I won't go into too much detail, but basically we used to think that pain was an output. You poke a pin there and it causes pain. Well, now we know that what actually happens is when you poke a pin there, it sends a message to the brain and the brain decides whether to release pain or not, okay? That's why your kids, for example, they won't cry until they see the blood, okay? And the reason why is because we know that there's a lot of different centres in the brain that play into that pain experience. So previous experience, for example, does. That's why when I drive past the dentist, I get a little bit of a fuzzy tooth. Or when you see a man get hit in the groin with a ball, you get that little bit of a feeling because previous experience tells you your brain has seen that threat and it's responding to an extent. So I guess what I'm saying is that if, for example, you've been told that you've got chalky bones or you're full of arthritis, that's going to increase your threat level and make you less likely to move and will actually increase your pain, okay, by having that threat associated with it. Motion is lotion. Let me, I might actually show you this for a moment. You don't actually need to be able to read it, but this line in the middle here, these are all studies that were done over a 20-year period. This line in the middle, over that side, was an exercise intervention. This is for people with arthritis, by the way. On that side was the exercise intervention, and on this side was rest. So in all situations, exercise made arthritis better. And in what ways? The ways that we're talking about over here: pain, reduced medication, walking speeds, quality of life. Now, these happen to be the results of a program that's being run in Australia at the moment. I'm not sure whether you've heard of the GLAD program. Anyone in the room heard of it? This is something that specialists are starting to go to prior to doing orthopaedic surgeries on hips, knees and ankles in particular. This program is a 6-week-long program with a couple hours of education in there so that you can learn about your joint. They take measurements. The first week you come in, 3 months and 12 months. All of your data is uploaded into a system. So this is out of tens of thousands of people in Australia, this data. And what they found is that this program for 6 weeks, although they do give you some exercises to continue on with if you'd like, reduced pain by 33% in the knee, 27% in the hip. It reduced medication usage by between 40 and 50%. It reduced walking speed, increased walking speed and quality of life. These two are factors for the older individuals that are sometimes involved in the program. In general, this is from a 6-week program. So you can see that there are, a lot of people think that why try the conservative management? It doesn't actually work, but it can actually work reasonably quickly so long as it's targeted, okay? I'll just go back for one moment. Motion is lotion, that's what we were talking about before. You want to keep readily changing the fluid within the knee joint and move it or lose it. Now, everybody's heard this saying, but what does it actually mean and what are the numbers? If I were to put a cast on your ankle, you would lose muscle mass, at least initially for the first week, at 7% per day, okay? That's big, okay? Not actually, you don't normally lose the strands themselves, but the strands reduce in size by that amount. And of course, that very quickly reduces, that pace won't keep up, otherwise you'll have no muscle there once you take it off. But as soon as you immobilise a joint, the body is really fantastic at adapting in both directions. So for example, if you did want to do that City to Bay run, it's great at adapting and improving your ability to be able to do that, but it also does the reverse. If you don't use something, it also doesn't want to feed it, okay? So if you're not using your bum muscles when you're running around, you'll end up with a flat bum because the body doesn't want to fuel areas of the body, muscular areas of the body that it's not using, okay? So you literally will lose it if you don't use it, okay? Very good. Now, I just want to, before we dive into questions, I also wanted to show you this. So this is released by Return to Work SA. So this is well, everybody would know who this mob are, but basically they insure our workers. So this is spinal imaging in asymptomatic patients. Now, what asymptomatic means is that people that have no symptoms, okay? So that's, if for example, if we had 100 people in this room, none of us had symptoms at all, and we took scans of all of our back, this is what you would find, okay, on your scans. So I guess what it means is that even though some of these things might show up on your scans, it doesn't necessarily mean disability or pain, okay? So I'm putting this out there to reduce the threat level of some of these things. I'm 35. So at 35, 52% of us have disc degeneration, and this study was 1,100 people, so they took a lot of scans here. Probably, I don't know how ethical it would be these days. Disc bulges, that one gets a lot of airtime. 40% of people my age have a disc bulge. Okay, so there's a pretty good chance I've got one. Disc protrusions or facet degeneration. You know, in fact, as you start to get up to 50 or 60, it's rarer not to have these things, okay? So it's handy to know that these things are a normal part of the ageing process, and that even though you have these things, it doesn't need to equal pain. It doesn't mean they can't cause pain, but it doesn't mean that they need to equal pain. So if you get a scan and you see 5 different things going on, please remember that it doesn't have to equal pain, okay? And that it is possible to live with these things without pain or disability. All right, any questions? Now, first things first, I'm very mindful that instead of talking specifically about one condition where we could have gone quite in depth, we've tried to cover quite a wide array there. So if there's any specific questions, more than happy to try and answer them for you.
When you're talking about the dynamic warm-up, I'm a shearer in that there, and I only do like the little bend over and all that there.
Yeah, so as in warming up.
Going for a run or?
No, you're better off doing things that are functional to what you're about to do. Okay, so mimicking what you're about to do. So it would be, you know, probably doing some of this, and it probably would be doing if, you know, ideal situation, you might have some of that stretchy band, and you can start doing some exercises with your arm prior to get it used to what it's about to do. Yeah. Now, in your situation, you'd be doing that 10 hours a day, 5.5 days a week. Your body is so damn good at it now that warm-up probably isn't as important as someone going out on a weekend and playing 90 minutes of sport in the cold in winter, because your body is super duper altered and adapted for doing that, okay? Yeah. So I would say in that setting, warm-up would be helpful, but you would already be very good, your body would already be very well set up to do it. So prior to that, it might be without the sheep, just going through some of the movements that you would do, maybe 20 of those, just to get the body used to doing it. And any sort of just, like you said, going for a quick run or getting on the cycle bike where you're going to vascularise everything and getting it moving is also a great idea. Yeah. So, yeah. Anything else?
Yeah, if you've got joints that are grinding, cooking, all that kind of stuff, any just day-to-day sort of stuff, anything you should be doing for that, like any of those supplements, fish oils, anything like that, actually useful or?
Supplements is an interesting question, and I know we've got some doctors in the house tonight, and I think that what you do need to be very careful of is that you're not doing any harm initially, okay? So, for example, fish oil, you can buy it on every shelf and every chemist, but it has a blood thinning impact. So you actually need to be really careful. Some people might need to be careful in actually in taking that. It might be good for others. So just be mindful that if you are going to take something, clear it with your doctor first. I know that that's what you see on the back of the pack and you think, meh, it's on everything. But it probably is worthwhile doing that if you're going to take that supplement every day for the rest of your life. I would say, general advice only, with regard to doing no harm, the fish oil and the omega-3s does tend to have the best bang for buck in a few ways. One, there have been studies to show that it helps with the vascularisation of the tissue around the joint, underneath your cartilage. So that's a good thing. And the second thing is it's also got pretty great evidence for your brain and your cardio system as well. So that's a bit of if I were to pick one, that's probably the one I'd go with, and I take that personally. But again, just be mindful that it can have other interactions.
So aside from supplements?
Aside from supplements, try not to pull away from activity, but you may need to adapt what you're doing depending on what it's causing. So for example, if you know that running's bad for you, you may need to look at cycling, which is a little less stressful on the knees. There's lots of evidence out there for doing specific strength programs for around the joint. Helps to stabilise the joint, and if you're not getting as much translation of the joint, you're not going to get as much pain. So targeted strength program, yes, supplements might help a little bit, and adapting the load that you're putting through it. It's probably not something I can tell you. I can't give you a full-on program to do right here and now, but there would be things that you can do for your joint, and through assessing it, would be able to tell you that. Yeah. Anything else?
Just from a footy club point of view, so you're saying really we shouldn't be putting lifestyle on these players unless they can't handle the pain?
Yes. It can, so the compression is still helpful, as we've learnt from Peace and Love, but there isn't a lot of evidence for it, no. Okay.
Can I clarify something there? I think your perspective is very interesting, the long-term recovery of the joint itself.
Yeah.
I think that if you do have a major trauma on the foot, or any trauma, I think the benefit of a full compression and a hot contact, for example, is that it will reduce bleeding, reduce bruising, and it will reduce the possibility of blood injury into the joint space and the subcutaneous tissue. So if I had someone come to me that had injury in the footy field, I would compress it, I would strap it up. But I don't think it probably impact the joint long term.
No.
What you're after. But it will reduce bleeding for sure.
There's some, I think, yeah, without going back and forth here, the body has natural processes to follow through. There are things that you can do to try and minimise those processes getting out of control, but we still do need to let those processes occur, is probably the answer to that. Yeah.
Conversely, what about heat packs afterwards?
So heat, you wouldn't want to do, normally they say up to 72 hours. You don't want to be using it in that period because you are going to stimulate more vascularisation or more blood flow to the area. So after 72 hours, I'd probably be even safer than that and leave it longer because you don't want increasing blood flow into that, swelling into that area even more, okay? Yeah. Cool. All right.
Thank you very much, Nigel. That was really...
Alice. Well, it's a pleasure to be here. I was just telling Alice that I started off my career here working at Jamestown. Is anyone here from Jamestown? No one. Oh yeah, so it'll be over a decade ago, I did my internship, a big portion of my internship at Jamestown.
You wouldn't know. I'm from Jamestown.
You're from Jamestown. Awesome. Not Peterborough? Everyone says they're from Jamestown that way, but no, it's good to be here. I'm going to talk about skin cancer. I'm going to keep it pretty sharp and snappy because it's getting late. I guess the question, why talk about skin cancer? Because it will happen to almost everyone in this room. 80% of basically white blokes will get skin cancer. I'm probably going to get a skin cancer. That's how common they are. 75% of people will obviously get a cancer that may very well become something that needs to be excised. So surgery is going to be something you're going to need for your skin cancer as well. And it happens to everyone. I mean, obviously there's a few notable people. Hugh Jackman, he's had about 4 cancers removed from his nose. Deborah Sutton, there's a whole bunch of Aussies that are quite prominent that have had them. But you don't have to be prominent, you don't have to be rich to get skin cancer. Farmers are going to get them, shearers, everyone that works outside. And you know what? It's us blokes that tend to work a lot outside. And that's why we're more prone to get skin cancer. You know, in fact, this is just some general stats I was alluding to earlier, but not only do we get more skin cancer, we're more likely to die from it. So when it comes to melanoma, which we'll talk a little bit in a second, you're 2.5 times more likely to die from it than a woman. Now, it's important for both genders, but blokes, who should we blame? Why are we dying 2.5 times more often than women? Who should we blame? Come on, who should we blame? Who? Ourselves, exactly. You and I, we can only blame ourselves that we're dying at a higher rate from melanoma because we just don't look after ourselves. And if we don't look after ourselves, no one will. So I guess how does it start? You know, skin cancer is not like an all or nothing. It's not like you have beautiful skin cancer. The truth is there's lots of little steps. And because there's so many little steps, you have a chance to intervene and get on top of it before it becomes something that you need to see me about or someone else. And the way it often starts is with these solar keratoses. Now people call them sunspots. Obviously solar means sun, so they're kind of, you can call them sunspots if you like. But solar keratoses, nearly everyone's got them, and I bet you've got someone, most of you here tonight. And I'm sure if you don't have some of your relies do, you see on the top of the head where it's a bit scaly, a bit rough. On the back of the hands, a bit scabby, a bit rough. For someone a little bit younger in the audience, sometimes it starts off with a bit of scale on your scalp. Now, have you ever felt your forehead and it's just a little bit rough and you think, oh, it's a bit of dermatitis or a bit of irritation? It probably isn't, actually. It's probably the solar keratoses, which are this kind of middle ground between good skin and skin cancer. And if you've got them, they're worth treating. They're worth treating. I often liken them a little bit to like specks of rust on the car. When you've got a speck of rust in the car, you can easily ignore it because, it's a speck of rust. It's not going to come to much anytime soon. But if you don't deal with that speck of rust, you're going to look like my grandfather's car. You're going to have a huge hunk of metal missing from the door, and that's going to take so much work to fix. So my point is, get onto it earlier. Deal with your skin when you start to get some of those little rough spots. Get them treated, and they can be frozen off. They can be treated with cream. There's lots of ways you can treat them. So get ahead of the game. Don't wait for cancer, all right? So pay attention to those sunspots. So if you leave a sunspot, what will happen? It'll get more and more irritable, more and more scaly. It'll start getting a little bit sore. You might have a shower and think, well, actually that feels a bit sore when I dry myself. There's a good chance that sunspot now has become a cancer. Now, I tell people that skin cancer is like fruit. There's just so many different types. I'm just going to focus on 3 of them: SCC, BCC, and melanoma. All skin cancers also have very different behaviours. I often tell people they're like children. Some kids will sit in the corner and read a book, and you'll have others that will just trash the place. Skin cancer is the same. You'll have some skin cancers that are really slow, very indolent, very lazy tumours. They won't do very much, so you don't have to rush too much to act on them. But others will just wreck the place like melanoma would, which we'll talk about in a second. So let's talk about basal cell carcinomas. Has anyone here in this room actually had a basal cell carcinoma? A few nods. This is the most common skin cancer and the one you're most likely to get, very much related to sun exposure. So you're not going to get this on the back of your thigh really, or on your scrotum. It's going to be on your face, your neck, upper back, forearms. Very much related to sun exposure. What's good about these? So it's a cancer, that's bad, but what's good about it is they don't metastasize, which means that they don't spread to your lymph nodes. So what you see is what you get, and so you'll have a spot that starts off like that, it'll just gradually get larger, and then usually the time that I see people is that when they notice it actually bleeds a little bit or it kind of hurts a little bit, that's when they usually come to me. Like for example, that one on someone at the moment probably wouldn't hurt you, wouldn't bother you at the moment. It's a perfect time to cut it out because it's nice and small, but eventually you'll find that in the centre it'll begin to erode, get a bit black and scabby, and you know, okay, this is now progressing. These need to be cut out. But this is the good skin cancer, so to speak. The other one that I'm sure some of you also have had in this room, because this is also very common, is squamous cell carcinomas. What makes these a little bit more different is you can see how this has got a bit of a horny kind of surface, a bit crusty, which is quite different to the basal cell carcinoma, which is very smooth and glossy. Squamous cell carcinomas are a little bit more dangerous. They do metastasize. So if you leave it alone, say you have something like that on your leg and you leave it alone, it'll get bigger, but if you give it a chance, it'll then spread to your lymph nodes and then spread throughout your body. So a little bit more vicious. Something like that definitely needs more attention. A BCC needs attention, but not so urgently. This needs to be cut out fairly promptly or treated fairly promptly. Again, really common, really common. Melanoma. We've all heard about melanoma. That gets the most press, but obviously it's not the most common. It only represents about 4% of skin cancer. So it's not anywhere near as common as sometimes people think it is. But the reason we harp on about it is that it's vicious. Like it wants to kill you. It wants to kill you. And the name of the game with melanoma is pick it up. And you know, it's sometimes very tempting to rely on other people to pick it up for you. But most of the time, and we've studied this several times, 70% of melanomas are found by you, by us. You find it yourself and you show it to your doctor and it gets attended to. So you have a big part to play in finding your own melanoma. A lot of this is intuitive, but I want to go through it. So, you know, obviously moles come in all shapes and sizes. There's lots of different types. We grade them in different ways. But what is usually a sign of a nice, healthy mole is it's nice and symmetrical. The colour is pretty uniform. It doesn't look like it's bleeding or hasn't been irritable or itchy. Just looking boring. You want a boring mole. Alarm bells should come into your mind when you see moles that you can see here a little bit black on the edges. I mean, this is completely, even to your eye, this looks completely chaotic, completely asymmetrical. These are the features. If you've got a mole that looks like that, show it to someone. You've got to get that seen to, and probably just get it cut out. See how this is pink? You won't believe, what makes it really, I guess, tough, very hard for all of us, is that a fair portion of melanomas are actually pink. Everyone thinks melanoma has got to be black, and most of the time they are, but often they're pink. So never, if you've got a pink spot that's not quite right, it's sore, it's bled a few times, and someone said to you, no, it's fine, it's fine. Don't just say it's fine. It could very well be one of these, pink or amelanotic melanomas. So keep that in mind. We've touched on that already. So I guess the reason that you want to do all this, I'm putting up a few gory photos. Is that all right? I can't put up gory photos over here. I can't put them up anywhere. So this is a chap I saw not that long ago who had a mole on his face. Didn't get seen to, thought it'd be fine, and comes to me a few months later. And this is the same, that's that mole that's just spread across his face. So this is a locally invasive metastatic melanoma. What do you think happened to this guy? 3 guesses. Yeah. No way he can be saved. But it started off with a mole on his face, and I know we're all busy. No matter what your work of life is or what you're doing, we're all busy. And it's so easy to kick the can down the road and think, it's probably been there for ages. No. Get it seen to, I said, because no one else is going to make you see a doctor or get it seen to. And the reason we die so quickly from a lot of these things as guys is because we kick the can down the road. All right, so I want to show you a couple of benign things that often get mistaken for melanoma. Because often people show you stuff and you think, should I be worried about that? I don't know. This is something that all of us are going to get. And I'm sure if you don't, your mate does. You have these what we call seborrheic keratoses or age warts. I'm sure you've seen a few backs like that where they cover these like warty brown spots. Often you might have a few on your face. As you get older, you often get quite a few of these like this on your temple. And we look closely, they look warty. These are so benign. I'm going to get lots of them. Everyone gets lots of them. A little bit genetic, very much related to sun exposure, but these are not cancerous. So don't stress about those at all right? They occasionally get itchy because they dry out, but they're not cancer and they have no cancerous potential. Now, treatments, surgery, I cut out about 1,500 cancers a year, and there's lots of people liking to cut out lots of skin cancer. And it gets tiresome for people. I'm sure if you've had a few things cut out, it's not fun. Even if it's a small excision, it'd be nice if there are alternatives. And the future is very bright. I think that in 10, 15 years, there'll be a lot less skin cancer surgery than we are doing now. So just a few options I want you to be aware of, because there's going to come a time you want to have something treated or you need something treated. And it's good to know what options do you have other than cutting things out. So there's a few chemotherapy creams, and they've been around for a while, but they're getting better and better. And they're creams that we can use for cancer that's a little bit thin, or is thin. And really quite clever technology. So if you have a thin skin cancer, there's some creams that can do it. Did you put your hand up? No, yeah, cool. Radiotherapy. Now, radiotherapy, it's always like, it has those awful connotations. You think, God, you remember your grandmother having radiotherapy in her lung and how bad that was. Things have changed so much. Radiotherapy is actually quite cool. It can work really well. I think what's bad about it is it doesn't really work in places like this because it's really labour intensive. If your GP says, think about radiotherapy, it's a lot of driving. So you need about 15 to 20 treatments, if not more. That's not really plausible out here. Brachytherapy. So this is a new technology, and I hope to have it at Flinders very soon. And you may actually see it on Channel 7 only like a couple of weeks ago. So we have a cream that has a radioactive isotope in there that releases energy, and we place it on the skin surface like this. So you can see the picture probably doesn't shot nicely, but there's a cling film, a bit of film on the skin, and there's a tumour that's been outlined with a pen. And we put this cream on there that contains rhenium, which is an isotope. And that isotope gets into the skin and kills the tumour over a period of about 6 minutes. And then it heals up beautifully. One treatment. So again, not going to be straight away available out here and so on, but 5-10 years, this will become mainstream. So surgery won't always need to be the only thing you've got up your sleeve. Injection. So some people have really bad cancers on their head and neck that aren't resectable. I'll inject them with drugs like 5-fluorouracil and methotrexate. So there are some injections I can inject into tumours to make them regress and go away. So that's another option. And of course, as I'm sure you've heard about on telly a lot, all those fancy immunotherapies for cancers of all different types. These are just drugs that are trying to get your own immune system, if you like, to kill your own tumour. And that is the future as well. I'm more than happy to explore those more in detail afterwards. You can come to me. So, how do I look after myself? All right, this is an important one. So, look, lifestyle is really important. We know if you eat well, you're setting your body up to be able to detect its own cancer and deal with malignancy and avoid things either starting or progressing. Nicotinamide. Who's heard about nicotinamide? Or what is nicotinamide? Does anyone know? It's just basically like vitamin B. We know that if you take vitamin B, or nicotinamide, which is a version of it, morning and evening, you get it from the chemist, over the counter, cheap as chips. It reduces your skin cancer risk by 23%. 23. Now, that's pretty cool for something that you get over the counter from your chemist. So I would say for anyone here that's getting a lot of skin cancers, or just about to, or if you've got a friend that's getting lots of skin cancers, tell them to read about nicotinamide. Well used. I use it at the Flinders Medical Centre. I chair the high risk cancer unit and we use it on our patients there. It's cheap, it's over the counter, 1 tablet in the morning, 1 tablet at night, and it reduces skin cancer risk by almost a quarter, which is fantastic. So I do recommend that. Now,
does that come in Vegemite?
Yeah, it does. It does a little bit, but you'd have to eat a lot of Vegemite. But that is a part of a good lifestyle. I think if you've got malnourished, you don't have those, those vitamins in your system, for sure you're making yourself more vulnerable to cancer. So Vegemite, for sure, it's a good part of a healthy diet. Protect your skin. Look, I grew up on a farm down the Fleurieu Peninsula, and I'll be the first to admit, when it's hot, it's dusty, wearing long sleeves, having sunscreen on your face, it's hard work. It's hard. And all you can do is your best. That's really all you can do. But I do think that long clothes is the way. Sunscreen, as I said, it's hard sometimes to put it on, and it wears off. So you can put it on at 8 o'clock in the morning, but by lunchtime it's not doing very much. But if you wear a long sleeve shirt, collar up, it's going to serve you well throughout the day. So you have to start habits. If you're not in the habit of wearing a long sleeve shirt, long pants, you got to start. And I don't think you need to go and buy anything fancy. Often you'll see these cancer websites selling expensive shirts and blah, blah, blah. Nah, look, you can get something from Big W, frankly. Some loose shirts from Big W, that'll be enough just to block out some of the light. Really, really important. Sunscreen, that. I'll talk a little bit about it more in a second. Lip balm. Especially for the fair guys in this room, which is most of us, or most of you guys, I'm a little bit darker than you. The lips cop it. The number of cancers I cut from lips is huge. And it always tends to be the farmers and the tradies, the chippies. Their lips just get baked, and it's the lower lip. So we're really good at putting sunscreen on our noses and the tops of our ears, but our lips, we let them just get cooked. So I do think you should have a nice lip balm that's at least 30 or 50 plus. Again, they're really cheap. Have them in the ute, have them in the tractor, have them around the place, in your toolbox and so on. Glasses. Take photos. Our memories are shocking. You look at a spot, you think, oh, yeah, not sure, has it been there for long, I don't know. Take a photo of it. We've all got cameras on our phones, take a photo of it, look at it 6 weeks later. If it looks worse, you think, shivers, all right, I better get the scene too. If you just rely on your memory, think, no, it's just the same as last time. No, it's not worth it. Just take photos. It'll help you make a decision about what you're going to do with your spots. See your GP. I'm a dermatologist, so I see the kind of the tough problem, the challenging situations. But a good GP can solve most of your problems. You don't need me most of the time. And there are some great GPs out here. So I think get yourself keyed into one and trust them. There's lots of skin cancer doctors going around the place. They're a bit hit and miss, to be honest. There's some great ones. There's some, entrepreneurial ones. But I think just your family GP is the person to go to, and they'll tell you if that's something they can fix or send you one. But they can fix most things by far. And look after your friends. The number of people I see that come see me because their mate said, oh, bloody hell, just go and get it sorted, And I think you all have that role. If you got a mate that's still got that spot on their nose that's it's been bleeding since you last saw them 2 months ago, just tell them, mate, just get it fixed. This is ridiculous. Because, as I said, we're all busy. You can't think, oh, no, I'll leave it. It'll heal up. So advocate for your friends and your mates. Now, sunscreen, just a little bit about it. So, you know, we're lucky in Australia that we regulate this a little bit, because you have to be confusing here products that say 15 plus, 30 plus, 50 plus, and sometimes you'll have friends that bring something back from Europe, it says 100 plus, you think, oh, what should I buy? In Australia, we've capped labelling to 50 plus, because anything above that is really not, it's a little bit misleading. So if you see a 15 plus product will knock out about 90% of the radiation, all right? So 93% blockage. 30 plus, 97, 50 plus is 98. 100 plus, for example, is only about like 98.2. That's why we don't actually label any more above 50. So my point though from this slide is, you've got to get 30 and 50. Don't worry about high numbers, that's nonsense anyway. 15 is just too low. So if someone's giving you 15 plus, finish it, but I wouldn't buy 15 plus. And yeah, people often will say, oh, you know, I tan really well, I've got Dutch genes, blah, blah, blah. I tan, great, good for you. But that's equivalent of a 2 plus sunscreen. So it's great, but not great. All right, so don't rely on your ability to tan. Another key thing is, right, who has that sunscreen in their ute or in their car? You do? Yeah. Chuck it away. You might as well put on your grandma's lavender oil or something. Heat destroys it. It's very, very photolabile and heat labile. So what I mean by that is that it degrades really quickly. So if you have it in your car and it's been cooked there, 50 degrees on numerous days, you put it on and you might get 10 plus out of it. Yeah, and sometimes you experience that yourself. You think, I put sunscreen on today, but I still got burnt. And it's probably because the sunscreen was just dead. It was dead. And don't let it get too far from expiry dates. And it's easy. I mean, I've had sunscreen and I put it on, I think, geez, this expired 2 years ago. Time flies, but expired sunscreen dies. And light destroys it as well. Now, thankfully, a lot of the containers are impermeable to light, but sometimes people decant it into like clear containers and stuff. Light kills it, right? So it's not stable. Get small containers. Don't buy big, budget kilo packs if you're not going to use it quickly. Get small containers, use it frequently, and keep it in a cool place. So again, like in your toolbox, I don't know, where it's not in a hot car, basically. All right. So I guess my take-home message for you guys is that you are the masters of your own health, and it's a message to myself as well. And that no one's going to look after you except, there are going to be some people, your loved ones will. But, truthfully, it comes down to you. You're the one that's going to pay attention to your skin. You've got to go and see someone about it. And if you don't, this is what ends up happening to you. This is someone I cut out a tumour of yesterday morning. This is a squamous cell carcinoma. So you remember I showed you 3 cancers? The first one's a BCC, which is a bit glossy. That's the good one. Then there's the one that's a squamous cell carcinoma that's a bit kind of horny and it has that crust. This is a squamous cell carcinoma. It's lost its horn because it's dying on itself, it's imploding. But this guy is probably going to get lymph node involvement. But if he'd seen me 6 months earlier, it could have been such an easy snip and clip job. So don't let this be you. That's my parting message to you. Don't let this be you. And key yourself in a good GP. And if you need a dermatologist, there's many good ones in Adelaide. All right? Any questions for me?
Should we be going to a skin clinic once a year or anything like that?
Look, I think it's very variable. I think sometimes it's worth getting a skin check just to set your baseline and see how your skin is. And if it's, a good doctor will then say, look, I think you're pretty low risk. See me in 5 years. But no, when people come to see me for an annual skin check, some people, I see some people every 12 weeks. They have so many problems. But I see many patients, I say, look, your skin's not bad. Come and see me in 5 years or something like that. So no, I don't think every chap needs a skin check each year. Sometimes it's a little bit overkill. As you get older, obviously your risks of skin cancer rise, and that may become applicable, but don't feel like, you're pretty young, I don't think you probably need a skin check each year. Yeah. Any other questions?
Is there any history with melanoma?
Definitely, hugely. Yeah. Approximately you're 25% more likely to get a melanoma if your first degree relative has, for sure. And that makes sense. A lot of cancers run in families: breast cancer, bowel cancer. There's a lot of there's a genetic component to it, and we know that well because children get melanomas, and you think, well, a kid has, how much sun has a kid had really? So they also got genetic weakness to it, or someone that's 25 years old. Jared Ruffhead, for example, the footy player, got a melanoma in his lip. Really, how much sun has he had? It's probably more of a genetic, or a big component would have been a genetic weakness. Yeah. So yeah, you can blame your parents as well.